So welcome all for the preferred practice pattern seminar of Jharkhand Ophthalmological Society, as well as Cornea Symposium of Jharkhand Ophthalmological Society. We have very eminent national speakers today, as well as entire Jharkhand's cornea specialists have joined. The postgraduate students, they have also joined across our state from all the medical colleges and DNB institutions. So over to Jharkhand Academic Research Committee Chairman, Professor Sunil Kumar, who is the head of Rio Rims Ranchi. He is going to introduce our 5 national speakers, Dr. Vardhaman Kankaria, Dr. Nivedita Narayan, Dr. Soumya Basant, Dr. Divya Manohar, and Dr. Prafulla Marana. So over to Dr. Sunil Kumar. Please share the slides.
Thank you, ma'am. So on behalf of JHOS, I welcome everyone on this master class of cornea and paper practice pattern. So we have the 5 national speakers in this program. So first I will introduce Dr. Vardhaman Kankaria. Can I have the slide, please?
Yes, please wait.
So
yes.
Yeah, so Dr. Vardhaman Kankaria needs no introduction. She is ever young looking, very dynamic and a smart guy. And is the ex-chairman Scientific Committee, Maharashtra Ophthalmological Society, member Scientific Committee, AIOS, International Council members, member Scientific Committee of the International Keratoconus Society, chairman of the Asian Eye Hospital, Pune, former honorary secretary, MOS, is the 55 international publications, more than 1,300 citations. That's a great number. 14 Best Paper Award, 32 Life Surgery, 7 prestigious Oration Awards, and gold medals of more than 45,000 refractive surgery. And is the only Indian LASIK surgeon who is trained by none other than the Professor Pali Karis, who is the father of the LASIK. He is the IGO section editor of the refractive surgery. He was news section editor of the refractive surgery. He is the alumni of the Sankar Netralaya, Chennai, University of the Great Greece, and Bascom Palmer Eye Institute, USA. So welcome Dr. Vardhaman Kankaria with JHOS this CME. So next I will introduce, next slide please. Yeah. So I welcome Dr. Nivedita Narayanan. She is the senior consultant with a special focus on cataract surgery, including femtocataract, and the lamellar corneal surgery, including DSEC, DALK, and LK, and the refractive surgery, especially SMILE. She is the deputy director of accreditation, safety, and quality assurance of the hospital. She is the FECO fellowship from the Medical Research Foundation, Chennai. She received the advanced training in cornea and transitioned to the cornea and refractive services in 2006. She has attended numerous national and international conferences, presented papers, and conducted instruction courses in wet labs, published extensively in peer-reviewed national and international journals, and she is passionate about the teaching and regularly trains students and fellows in the above area. So welcome Dr. Nivedita Narayanan. So next slide, please. So next speaker we have is the Dr. Soumya. She is the fellow in cornea and external eye disease from the RIO, Bangalore Medical College, and she is currently working at Jamindar Microsurgical Eye Center as a cornea consultant. And she is a yoga enthusiast and keen interest in the agriculture. So this is the extracurricular activity. So welcome, Dr. Soumya. So next we have with us, we have Dr. Divya Manohar. So she has the clinical research interest in the corneal diseases like dry, Sjogren syndrome, MGD, keratoconus, refractive surgery, phakic IOL, keratoprosthesis, lamellar infiltrating keratoplasty, SLT, femtosecond cataract surgery, and eye banking. She has done the MicroMaster in Clinical Epidemiology from the University of Michigan, fellowship in cornea and refractive surgery from Urban Madurai, MS from the Urban Madurai, and MBBS from the Chennai. She has a lot of surgical skills, including 2,000 plus refractive surgeries, DALK, DSEC, DMEC, optical and therapeutic penetrating keratoplasty, phaco, MSAS, iris claw, SFIOL, toric and multifocal IOL, corneal tattooing, patch graft, CXL, pterygium glue. And also in the field of the keratoprosthesis, OSSN management and combined anti-segment surgery. So welcome Dr. Divya Manohar to this JHOS CME. So this is all about the introduction of our guest speakers. So over to Dr. Bharti Sharma, I think, for the introduction of the local speakers.
Yeah. So thank you, Dr. Sunil. So can I have the next slide, please? So I have the honor of introducing all the cornea specialists from Jharkhand. So if I can have the slide.
Dr. Bharti, we have to introduce Dr. Prafulla Maharana also. Okay. Dr. Sunil forgot to introduce Dr. Prafulla Maharana.
Okay.
Dr. Prafulla Maharana, we are sharing his slide.
Yes,
he will join after some time. He is in JHOS urgent meeting.
I think when he will join, then we can introduce him.
Host?
Ma'am, when he will join Dr. Prafulla, then we will introduce.
Okay. The host has done something. What has happened to the host? Okay, we are doing.
Yeah. Ma'am, so the slides of the local speakers.
Yes.
Slides of the local speakers.
So Dr. Bharti, please introduce the local speakers. They are all prominent, eminent cornea surgeons from Jharkhand.
Yes, ma'am. So can I have the slide?
We are showing it.
So I think I will start with nobody else than Professor Dr. Sunil Kumar, who was introducing all the national speakers. So by the time they are sharing the slide, Professor
we have shared.
No, it is not visible. Not visible. Its prior slide is visible.
Okay. Just wait, please.
Yeah. Now it's come. Do the slideshow. Yeah.
Yeah, please start.
Yeah. So Dr. Sunil Kumar is professor and head of the department, Rio RIMS Ranchi. And he's also the medical director of Government Eye Bank, and he's the chief cornea services of RIMS Ranchi. He has done his MS ophthalmology and senior residency from our prestigious PGI Chandigarh. And he has published more than 50 papers in national and international index journals. He has a lot of awards which go up to him. Best Paper Award in 2005, and then Poster Award in 2007, winner of AIOS Quiz 2014, Dr. B.N. Gupta Endowment Ecoin Award 2022, East Zone Ophthalmological Society State Award for Jharkhand in 2023, and late Dr. R. Singh Memorial Oration Award in Varanasi 2024. He is also got Distinguished Ophthalmic Teachers of India Award in 2024. Professor Sudhir Kumar Endowment Oration Bihar Chapter 2025, and he's also the Associate Editor of International Journal of Medical Ophthalmology. Welcome, Dr. Sunil. I think we all will be enlightened to hear and from the experience that you have. And RIMS is one of the largest hospitals here in Jharkhand, which caters to most of the patients. Can I have the next slide, please?
Yes, we are doing it. Please wait. So next is our another speaker, Dr. Bharti Sharma, who is introducing all of you. She is the head consultant and HOD, Tata Main Hospital, Jamshedpur. She is the cornea. She has done her cornea and cataract fellowship from Shankar Nitralaya, Chennai. She is the gold medalist, Shankar Nitralaya, Chennai. She is the former consultant cornea and refractive services, Shankar Nitralaya, Chennai. She is the former senior consultant, Apollo Bramwell Hospital, Mauritius. Presently head consultant and HOD, Tata Main Hospital, Jamshedpur.
Thank you, ma'am. Yeah.
So we are honored.
Thank you, ma'am. Thank you so much. So we have with us Professor Dr. Seema Kumari, and I welcome you, Dr. Seema. She's a very young and budding associate professor from Department of Ophthalmology, MGM Hospital and Medical College, Jamshedpur itself. She is the former head of the department also, and she has worked as a nodal head of MGM Eye Bank. She has done her MS ophthalmology from Darbhanga, Bihar, and senior residency under Dr. Sunil himself. She was telling me in the morning from RIMS Ranchi. She has fellowship in cornea and refractive surgery from Chitrakoot, again a very prestigious hospital in our country. And she's also fellow of IMA College of General Practitioners. She has published more than 40 papers in national and international journals, and she is a very active member in various research committees. She is winner of very prestigious Dr. Dukhan Ram Gold Medal Award for Best Paper on Keratoplasty. And in 2010, she has presented many papers in AIOS, Jharkhand Ophthalmological Society, Bombay Ophthalmological Society, and MP Ophthalmological Society. We welcome you, Dr. Seema. And I know that you are a very young and you are always very keen to teach our junior doctors. So I am very sure all our PGs will learn a lot from you. Thank you so much. Can I have the next slide,
Yes,
please?
yes. Doing it.
I think it should be Dr. Nidhi.
Yes.
So, Dr. Nidhi, I will start slowly. Can you please display the slide?
Slide speaker.
Dr. Nidhi.
Just wait.
Yeah.
Is it visible?
No, ma'am.
Is it visible?
Yes, ma'am. Yes. So Dr. Nidhi Gatkar Kashyap is again a very young budding cornea surgeon. She is from our very own Kashyap Memorial Eye Hospital, Ranchi. The slide is not, yeah. So she is MS gold medal in MS, and she has DNB, FRCS Glasgow, Edinburgh. You can name all the degrees that she has, FICO, and she also has ICO. She has a fellowship in cornea and external diseases. She is the chief consultant, and she also heads the eye bank, cornea and eye bank services from Kashyap Memorial Eye Hospital in Ranchi. Welcome, Dr. Nidhi.
Hello, ma'am. Good evening, everyone.
Yeah. So, next slide.
Yes. Is it visible, Dr. Pooja Kumari?
No, ma'am.
No.
Just wait. Is it visible?
No.
Not yet.
Okay, wait.
Yeah, now it's visible. It's visible now.
Yes. So Dr. Pooja Kumari, again, our own from Jamshedpur. I'm very proud of the fact that she is here. Dr. Pooja Kumari is a senior consultant, Department of Ophthalmology in Tata Motors, Jamshedpur. She has done her MBBS from Jipmer Pondicherry, where she has had a gold medal, MS again from there, and she also has DNB and FICO. She's ex-senior resident from Dr. RP Center, New Delhi, and she has done senior residency in cornea, cataract and refractive surgery and ocular oncology. She has received Best Senior Resident Award in year 2019-20 at AIMS Delhi. She has published more than 20 publications in national and international index journals, and also has few chapters to her credit in corneal infections and inflammations. She is currently working as a senior consultant and acting HOD at Tata Motor Hospitals in Jamshedpur. And she was also formerly associated with Kashyap Hospital in Ranchi. So welcome, Dr. Pooja. Are you there? Yes.
Thank you, ma'am.
Yeah, thanks. So can we have the next slide, please?
Yes. Yes. Just wait for 1 minute. we have two more speakers, Dr. Neha Gandhi Madan and Dr. Poonam Rawat.
So both are again from Jamshedpur. So we have a lot of cornea people in Jamshedpur.
Correct. But eye bank is most developed in Ranchi.
yes, ma'am. But I think we are coming up with one eye bank here in
yes.
hospital also.
Yeah.
And that will also help us. So I think it should be Dr. Neha Gandhi Madan and Dr.
Yes, Neha Gandhi Madan.
Dr. Poonam Rawat.
You have the slides of Dr. Neha Gandhi Madan in your mobile. You can read that.
Yes, so I can speak about Dr. Neha. Are you there?
Yes.
Dr. Neha?
She's there. She's there.
So Dr. Neha is welcome. Dr. Neha Gandhi Madan has her diploma in ophthalmology from D.Y. Patil Medical College and Hospital, Navi Mumbai. She has secondary DNB done from Shankarai Hospital, Coimbatore, and after that she has gone to do a long-term fellowship in cornea and anterior segment services from LB Prasad, Hyderabad. She has cleared her FI, CO and FICO corneal exam, and currently she is working as consultant cornea specialist in Jamshedpur at Jamshedpur Eye Hospital. Welcome, Dr. Neha.
Thank you, ma'am. Thank you.
Yeah.
Is the slide visible? Is the slide visible of Neha Gandhi Madan?
No, ma'am.
Okay.
So maybe it will come now. Yes.
Okay, so now we welcome Neha. Then next slide, please, for the Poonam Rawat.
Poonam Rawat, yes. So Dr. Poonam Rawat, welcome. So Dr. Poonam has done her MBBS from Mumbai, and DNB of Health from Noida. She has a fellowship in cornea and anterior segment from Arvind Eye Hospital, Madurai. And she's associate ophthalmologist and cornea specialist in Jamshedpur Eye Hospital. And she is very dynamic and does a lot of cataracts and corneal surgeries. We welcome you, Dr. Poonam. Are you there?
Yes, ma'am. Thank you, ma'am.
Great. So now, ma'am, we can start with the webinar. Thank you so much.
Yeah, now over to Dr. Vardhaman Kankaria for his talk on keratoconus.
Thank you, ma'am. Yes. First of all, thank you to Dr. Bharti Kashyap, ma'am. I've had privilege of knowing ma'am and sir for several decades now. They are a great inspiration. And thank you, ma'am, for the kind invitation. I would like to also thank the other office bearers of the Jharkhand Ophthalmic Society, Professor Sunil Kumar, sir, and Dr. Bharti Sharma, ma'am. Friends, I'm going to talk to you about, as I understand, this is going to be for postgraduates. I hope my slides are visible.
Yes.
Okay, great. Yeah. So, as I've been told that this is going to be for postgraduates, this is a topic that you will probably not get in your ophthalmic textbooks. So I will try and make it simple. We have all heard of cross-linking that is done for keratoconus, but I'm going to talk to you about something which is more advanced, something in which give your patients more functional vision that you can actually get only through cross-linking. And this is the topic of my today's talk. I don't have any financial disclosures. So friends, we all know that collagen cross-linking is well-established treatment. And this is being done for more than 2 decades now, where UVA light along with the riboflavin creates production of oxygen radicals, free radicals in the intrastromal corneal filaments, and then it causes induction of collagen cross-linkage. This collagen cross-linkage is known to decrease cornea's deformability and is known to halt keratoconus progression. This was first time that such an entity was developed by Professor Theo Zeiler and his team, and in which it was now then possible to stabilize keratoconus. Now let us look at one very interesting case. So this is one of our earliest cases of cross-linking or keratoconus back in 2007. So Swati was actually a young girl who came with progressive keratoconus with a low uncorrected visual acuity and a relatively low best corrected visual acuity of 6/18 or 20/60. She had a relatively thicker corneas of for keratoconus about 490 micron, and she was contact lens intolerant. Because she was having progressive keratoconus, of course, the best approach was doing a Dresden protocol. That is a traditional protocol which was started in those times, which was a long form of cross-linking. And as you can see on the right side, on the lower topography, you can see the pre-operative, and on the upper topography, you can see the post-operative scan. And the one on the left side is the differential map. You can see very well that not only that this patient achieved a topographic stabilization, but she actually showed some more flattening and improvement in topography as well. So as doctors, we were very happy, but Swati was not yet happy. And the reason was she was still having poor best corrected visual acuity because she was still contact lens intolerant. Then we went on to realize that many of post-CXL patients do not achieve good functional vision, especially when they cannot tolerate contact lenses. And that is because of unaddressed component of remnant irregular astigmatism. This irregular astigmatism, as we all know, is the hallmark of keratoconus. So the ideal treatment of current times should have not only stabilization of keratoconus with cross-linking, but also visual rehabilitation of these patients by doing something what has been nomenclated as the CXL Plus platform. CXL Plus is a brainchild of one of my mentors of keratoconus. His name is Professor George Quinones. So we will go through some of this CXL Plus approaches. And to begin with, we are going to discuss about CXL and then following up on the second sitting with topography guided PRK. Konolopoulos et al. From Greece actually devised a two-stage procedure in which he first performed a cross-linking to stabilize keratoconus, and about 1 year after cross-linking, he performed a topography guided PRK. So my friends who are postgraduates, just to tell you what is a topography guided PRK. Topography guided PRK is the one in which you feed the topography of the patient to the examiner, and the examiner tries to smoothen the topography, regularize the topography. So in this case, the attempt was made to improve the functional vision. So although the functional vision improved in these patients, but it had two nagging problems. Number one was it was removing already a cross-link cornea, and the haze was also seen more than the routine PRK. Therefore, Quinones et al. From our group and Konolopoulos also at the same time devised and published in 2009 a protocol which is now known as Athens protocol. What is Athens protocol? Athens protocol is when you're actually doing a partial topography guided PRK, and immediately in the same sitting, you are doing a cross-linking treatment so as to give regularization of topography on one side and stabilization of keratoconus on the other side. So this combination was what is called as the Athens protocol. So let's look at one example. So this is a 26-year-old patient who comes with best corrected visual acuity of 6/12 with a keratoconic patients with reasonable thickness of 467 micron. In this case, when we have done a topography guided PRK, as you can see in this case, this feeds the topography to the examination, and you are actually regularizing the topography in this way. So with this approach, it is important for you to know is that the correction is only to regularize the topography. It is not to actually give the refractive correction to these patients, or therefore you are not supposed to attempt full correction. You should not ablate more than 40 microns or at max 50 microns by keeping a smaller optical zone. So in this patient from 6/12 vision or 20/40, the patient actually went on to have 20/20 vision by a significant improvement in topography, as you can see in this patient as well. Then we realized that if this is better, can this be proven in a contralateral study? Therefore, we went on to perform a contralateral long-term evaluation in one eye by doing only cross-linking, and in the other eye by doing Athens protocol in set of 31 patients. So in this patient, this was published back in 2016, almost a decade back in a prestigious journal of ophthalmology, where we showcased that when you have Athens protocol, there is more gain of uncorrected visual gain of 30 letters versus 8 letters only on the cross-linking. The best corrected visual acuity improved in Athens protocol by 8 letters on logMAR as against only 4.7 letters with the cross-linking. And the most important thing, none of the patient had lost any lines of Snellen and chart. That shows a great amount of safety. What about the long-term success? This is a 10-year outcome study which was published on Athens protocol by Kanolopolis, which has actually shown a great amount of safety and efficacy over a very long time, which is about a decade. Now, friends, there are a lot of patients who may have moderate keratoconus but have very thin cornea for doing topography guided PRK. And in these patients, what can we do? So this is a 24-year-old patient who came with now only a 420 micron thickness. So CXL was possible, but topography PRK was not possible in this case. So the question was, we all know that we have to remove epithelium when we are doing cross-linking, but can we use the epithelial removal technique itself to improve the topography of this patient? So we all know from a study by Reinstein et al. That he has shown that epithelium in keratoconus is not regular. It is actually of donut shape. That means it is thinner at the apex of the cone. It becomes thicker as we go along in the periphery. By using the same hypothesis, you can see that in this patient, epithelium is thinner. So if you're actually using a PTK of 50 microns, then you're actually topping off not only the epithelium, but you are also smoothing a bit of underlying stroma where the topography is going to be steep. Therefore, in these patients, you can actually regularize cornea by just doing a PTK. So this smoothing effect of PTK was devised, and when it was combined with cross-linking, this was called as Cretan protocol. Cretan protocol was first devised by our team led by Professor George Quinones, which we published back in 2013. You can see in this case, this is the pre-operative and the post-operative topography showing an excellent smoothing of topography. So then we went on to do one more long-term study in which we did Cretan protocol in one eye, and we just did a Dresden or a standard protocol in the other eye in set of 31 eyes, and we did see that there was a statistically as well as clinically significant improvement in patients who had PTK CXL versus only regular CXL with manual epithelial debridement. We published these studies in variety of international journals, and now we have recently also published a long-term result of this Cretan protocol in set of 23 eyes over a duration of follow-up of 5 years. Now let's come to the 3-year third case scenario. So this is a case scenario which is common in patients who have moderate or severe keratoconus. You can see there is a very high asymmetric irregular astigmatism in this patient and very high amount of astigmatism going to almost 15 diopters. So if you have a 15 diopter astigmatism, of course, there is no way that the topographic guided PRK or a PTK can help this patient. Therefore, the best approach is what is called as the INTACs. INTACs are intrastromal ring segments. So they can now also be done with biogenic implants, which I'm sure that Dr. NVN is going to speak now very soon with the help of CARES. This has the buttress effect in the periphery and smoothens and smoothens and flattens the cornea in the center. Therefore, it is known to reduce irregular astigmatism to a large scale, especially in this kind of keratoconus. And then this can be done with the same sitting or after 6 months with cross-linking to stabilize keratoconus. So in this particular patient, you can see this is the pre-op on the lower side, post-op on the upper side. The astigmatism has reduced drastically from 15 diopters to very minimal astigmatism, and the vision has drastically improved in this patient from best corrected 2040 to uncorrected 2070. Now, this last case scenario is a case in which you may have a lot of patients where there are patients who have mild keratoconus with very good best corrected visual acuity still available, but has very high myopia. So when you have ensured that the patient is actually stable by doing cross-linking or stable on its own, at least for a duration of a year, you can actually take advantage of the current generation of toric phakic lens implants, such as toric ICLs. We have a large series of such patients. We have recently presented about 700 plus patients in our APO last year by one of our fellows, and it is going to be published soon in IGO. So you can see in this patient, after the ICL implant, the best corrected visual acuity improved to even 20/30 with very minimal astigmatism and uncorrected to almost 20/40. So friends, this is an algorithm that all of you can remember, is that whenever you have a patient who has keratoconus, of course, a patient who has deep scars, very thin corneas for cross-linking, very low visual acuity, cannot be fitted with cross-linking, you must plan to do a form of transplant, either talc or a PK, depending on the case. But yes, if the patient is better, has mild to moderate keratoconus, is showing no progression, then just tell them to avoid eye rubbing, follow up with serial photographies. But if the patient does show progression on topographies and has acceptable thickness, you can perform one of the CXL plus procedures, either CXL with topo-guided PRK, PTK, Intacs, or phakic lens implants, and thus give these patients a completely new quality of vision, giving them a complete treatment, not only stabilization, but also improving on their functional vision with this adjuvant treatments. So I'm going to leave you with the quote of well-known Mr. Thomas Edison, the world-renowned scientist, that there is always better way to do it, and we have to find it. Thank you very much for your kind attention. Thank you.
Thank you very much for enlightening us. And we are also doing regularly this Athens protocol, Cretan protocol, and TREC also. So what is your experience on TREC? Means TREC is actually a Narayana Netralaya initiative.
Right.
So have you compared this Cretan with TREC? There is a very little difference. We do PTK in Cretan, and in TREC, we just remove 20 micron stroma also over the cone. So do you do TREC? And if yes, have you done any comparative evaluation, comparison of TREC and PTK?
Yes, ma'am. Thank you, ma'am. I think it is a nice question. And as you have said, they are very close procedures to each other, because also in Kritan, you are topping of the epithelium and a bit of extra stroma at the apex of the cone. And because TREC can be done only with the Schwind exam lasers, where the Kritan protocol can be done by any exam laser. So in Schwind, as ma'am has said, you can decenter the focus and you can go locally at the apex of the cone and you can do a PTK. So we can say that TREC is almost doing Cretan protocol localized. So it's like doing localized Cretan protocol. And
actually, what you said now, that actually the cornea is thin at the center.
Yes.
So when you are ablating, even with Cretan, at the center, it is taking some of the stroma.
Yes, so it automatically smoothens the stroma.
It's like TREC.
Same thing like TREC. Yeah, correct. Very true. So it is like a TREC is a kind of offshoot of Cretan protocol. I believe both of them work very well with the amount, with the kind of examiner one has at disposal. One can choose either Cretan or the TREC.
But previously we were doing Cretan, but since the time we have got Schwind, we are regularly doing TREC. The TREC results are very good, and after the scleral contact lens, the vision improves a lot.
Yes, ma'am. Absolutely. Yes. Yes.
So thank you so much.
Thank you. Thank you, ma'am.
Vardhaman. And if you stay with us for some longer time, you can be the good discussant for other national speakers.
Yeah. Thank you, ma'am. Thank you, ma'am.
So the next speaker is Dr. Nivedita Narayana. So over to Dr. Nivedita. She's going to talk on her preferred technique on cares in keratoconus.
My slides are visible?
Yes. Yes, Vardhaman.
Yeah, thank you, ma'am. Again.
Okay, it's seen, right? Yeah. Am I audible? Okay. So my preferred technique of cares in keratoconus. Cares is corneal allogenic intrastromal ring segments. So where we use a donor cornea in the strip form to smoothen the cone in keratoconus patients, select patients. So whom do I offer? It is a progressive keratoconus, asymmetric cone, decentered, paracentral, clear cornea, thinnest packing not less than 350 microns, and those who are intolerant to contact lenses. So there is a specific indication for CARES. Exclusion criteria will be all inflammatory, lactating, pregnancy patients. Central cone, we don't do. Any thin cornea less than 350 microns, we don't touch. And other ocular and systemic comorbidities. So with this kind of cares, we also have the option of customization. So factors which will help us in customization is based on the severity, location of the cone, the zone, the steep axis where it is, and the pattern of astigmatism. Customization can be done by either single edge taper, double edge taper, or central. So when you customize, it is very personal to that particular individual topography of the patient. Instrumentation required are very simple. There is no big thing except for the double punch, and the customizer number 2 is a very important thing for customization and perfect positioning. 3 is the arc spatula-like thing which can help us in pushing, and we also mark so that you need a marker. So initial cases are used to do the Bowman's marking. It is very important thing because it helps in identifying the orientation of the graft while customization as well as while it is being pushed into the channel. But we have to be careful because it could be endothelial toxic. Over a period of time, you will know how these grafts behave and you don't need the Bowman's marking in the later cases. So let us see how I personally do it. So I take the 6 millimeter ring and see meridionally what is the astigmatism. So from this diagram, we know between A to B, the meridional astigmatism is high. At A, it is 14, at B is 10. So, and beyond that also there is 3 at C and 3 at D and 6 at C. So that area is what needs changing. You have to do the changing in the steep axis. But between A to B, we need the maximum thickness, and beyond that, we can taper. So this is actually customization. So when you create a channel on the host cornea, you do a channel in such a way that it straddles the area of the 6 millimeter ring, and then you create the graft in this fashion and push it into the channel with the Bowman side facing centripetally for the thing. So now these are the parameters of the intrastromal channels that I use. And I actually slightly enlarge the channel so that the pushing will be easier. Not more than 50% depth of the stroma in that 6 millimeter ring I do. Very important is when we use a normal examiner, centration is key. Just like how you do the toric lens, you have to mark the 6 and 9 o'clock. And then the central coaxial sighted clear corneal light also should be marked so that you can position the cone exactly on that. Now I normally do my DMEC. I remove the graft, I put it for staining. While I'm doing that, I prepare the CARES graft in the same. So you don't have to go for a special separate, that way you can save the number of corneas that you use. So without removing the outer ring, when you do, the thing comes out very beautifully. The central will be your 6.5 mm graft for a DALC if you want, and the outer 1.5 millimeter ring will be your CARES. Then you can go ahead. First, you'll have to remove. So now we are epithelial side up here. So you have to remove the epithelium with Wexel sponge. Meticulously, slowly, it will start falling apart. And then you use a hockey knife to gently scrape. You have to be careful not to scratch the stroma. It is only a surface polishing maneuver. So once the epithelium is completely removed, in the initial cases, you stain the Bowmans, and later on, you can just use it like that. Sometimes I have tried removing the ring and then punching. When we do that, you can see how the graft is getting distorted. So you don't get a you don't get a nice ring of the graft. It gets punched out in one area and then it is irregular. So I don't recommend that, and even an uncut. So if it is nicely cut, it should look like this, one ring and one stromal graft. So once that is done, you take the ring and place it on the cup cup is a very simple instrument where you can position it, iron it. So then you have to dry it using the Vexel sponge so that it becomes a little pliable. So the first step is to cut it into 2 halves. So I'm just gently drying it. Now I'm cutting it into 2 halves. You can use the normal 15-degree blade. So now we have a tape-like graft. So that can be straightened. Yeah, you can see that, how nicely it is coming. Now you can straighten it. So the top one is the Bowman side. So I'm just flattening it, pushing it to one side all over so that it is not twisted. It is very pliable when it is moist. So now I am bisecting it because we are not going to put the full graft. We are only going to put in that specific segment where we want flattening effect. So I am reducing its size. Sometimes you may need more. This is the best advantage of CARES. You don't need a large size of the ring, just like how we do in TACS and other things. This is placed superficially, so it can be of specific size. So once that is cut, you can see how it behaves. The fluffy side is the stromal side and the rigid side is the Bowman side. So you can't mistake this. So you don't actually need a marking. So once that is done, you go on to the customizer. You place it in the exact position at the 6 millimeter ring. So I'm just showing here there, 6 millimeter ring, you position it. And once that is positioned there, then you go ahead and mark. So you mark the clock overs where you want the full thickness, and you also mark the area where you want to trim it. So I have put both the videos simultaneously. You can see it. Yes, once that is done, you take it out and place it on a flat surface. Again, you position it in such a way that the Bowman's is rested flat on one side. Otherwise, it will slip. Your cutting the thing will be difficult. So once this is done, you now go for the final customization. You spread out the graft nicely, and then ends you can trim. So that is the end of the graft that you want. Both sides, you cut one by one. So now from the end to the first mark, you need to taper it. So you can cut the stromal. You have to be mindful to retain the Bowman side in both, because that is the thing which is going to give you the stiffness and the shape and the changing of the cone. So now you have the custom made. So you position it back on the same 6 millimeter ring and let it dry by the time you prepare the channel. 20 minutes is more than enough for it to dry. So now we go on to the patient. We have marked the patient properly, and you can create this kind of a, we have a single entry only, that is good enough. Once you are mastered the technique, single entry is good enough to go ahead with positioning. So this is how you mark the center and the clock hours. So once the channel is created, you will have to open in the platform, which is widely slightly a widened zone. After that, you can use the Y hook to gently open up the arc, the location where you actually want to position. So by the time all of this is done, the graft is dried. You have to be very careful when you take it, because otherwise it can fly. In this case, it is still in the sterile zone, so I have escaped. So you'll have to gently handle it. You can see how stiff it is. So you can insert it like an intact only. So you don't need anything. Once the channel is open, this beautifully goes in and sits in that place. So you have to mark the clock hours. Suppose in this case, I wanted between 240 to 300. So that area I have opened up. So this will nicely move from the 210 opening towards that. So it will all be nicely pushed in. So now let us look at some cases. This is case of a 23-year-old lady who had plano in the other eye, and this eye had a high astigmatism, and it's a progressive keratoconus. So along with the cross-linking, we decided to do CARES. Post-CARES, her vision is improved, her cylinder is drastically dropped, and she is able to wear glasses of this 20-month of follow-up. When you look at the sagittal curvature, the first one is the post, middle one is the pre, and the third one is the indifferent. So you can see a area of flattening exactly at the location of the graft. If you look at the epithelium, this is the corneal thickness. Corneal thickness also shows that the area of the graft is thicker than the other. So that is the difference. You can see that plus 39 is the area where the graft been inserted. If you look at the epithelial map, you can see centripetal to the area of the graft, there is a thickening. So this is a standard pattern we have noticed in the OCT picture. Also, you can see that inside of the graft, the epithelium is bunching up. So that is some kind of a compensatory mechanism what the epithelium shows in these kind of cases. We'll move on to the next case here. This patient is plano one eye, 15-year-old male. The other eye is -12, -1, 6'9" with his best corrected vision, but he has never worn glasses. We offered him DALK, he refused. So we tried to do cross-linking along with CARES. So you can see how it has been planned and how it has been inserted. And again, if you look at the sagittal curvature map, there is a considerable flattening in the center. And the corneal thickness map shows corresponding thickness. And here the epithelial thickening inside of the graft location is beautifully seen in this picture. Now we move on to the third case. This is a 16-year-old with the right eye -11, -4 at 3/60. So we offered her DALK. Again, the patient refused. So we went ahead and did CARES with cross-linking because the thickness is still 358. In the post-operative period, you can say similar effect, thickening of the stroma. Inside, that arrow mark is showing inside of the thickened stroma, you have the epithelial bunching up, like a compensatory mechanism. You can see in the slit view how beautifully the CARES is sitting, and the patient's refractive error is beautifully matching the other eye. So now he doesn't mind wearing glasses in both eyes. So these kind of cases is really motivating. And that is why I keep doing it. But unpredictability is there. So that is one word of caution. So none of the procedures are without complications. For this patient, we -6 cylinder, I thought it's an ideal case to do. She was doing fine. And then she stopped the steroid and she came back with a rejection-like episode, which eventually settled with topical steroids. Lucky for me and the patient, her vision was not lost. It was well and maintained. Now, next case is 25-year-old lady. She is actually a dentist who refused to wear contact lenses. So she underwent CARES with cross-linking. She came back with an infection. It was an MSSA. We put her on vancomycin. She was responding well. She came back with perforation. We glued it. But the whole area of the graft was perfect, including the channel. Only the place where I had put the suture, she had this problem. So I did not remove the CARES. Lucky for me, it healed very well. And her vision was still maintained. She did not lose it. So she's wearing glasses now. But in this case, the epithelial thickening was not classic like other. So probably the drug toxicity or something changes the way in which the epithelium fashions itself. So that is one lesson we have noted. So in conclusion, CARES is a useful tool meant for based on the meridional astigmatism at the 6 millimeter ring for a specific group of patients where you have a reduction in the refractive error smoothening of the cone with hyperprolate status is also managed. With our limited group, we are able to reshape and give some benefit to the patient, but the unpredictability is an issue, and we need to follow these patients on a long term. Thank you for this opportunity. It's an honor to be a part of JHOS. And thanks to Bharti Kashyap ma'am for calling me for this.
Thank you so much on elaborating on a subject which is not very well practiced even by the cornea surgeons mostly. CARES is a new concept. Not everyone, all the cornea surgeons, they do it. So our next speaker is
Ma'am, a few questions for Nivedita.
Yes.
Ma'am. Can I go ahead? Yeah.
Yes, yes.
Beautiful demonstration, very, very lucid, very clear presentation. So I think anyone who has seen it can go and do it tomorrow. It was that beautiful.
Yes, it was.
Yes. So, ma'am, I have some questions. You were mentioning about doing CXL surgery before doing CARES. So what is the protocol like? And
No, not before. So if, as we already know, say cross-linking will stiffen the cornea.
Yes.
So anything you want to flatten has to be in the normal virgin cornea.
Okay.
So you do cross-linking and then you do, you do CARES and then you do cross-linking on the same setting.
So what is the time period that you would suggest?
Same sitting.
Same sitting.
Same.
Okay. Okay. So does that induce any abrasions or anything of that sort, madam? Even putting a CARES segment, because you're altering the corneal surface. Have you noticed anything, or other patients?
I look at it as two different procedures. The purpose of CARES is to flatten the cornea. So that we do based on the prediction that we have calculated pre-op. The purpose of cross-linking for me is to stiffen and arrest the progression of keratoconus. So I don't look at it as changing the power or refractive correction. So when you combine the two, then each one serves its own purpose. And one thing, when you combine, you don't go for debriding the epithelium over the site of care. So it has to be a little less. So that's the only hitch.
Okay. But that's where the most steepening is there, right, ma'am? The most of the steepening is there. We are flattening it at that part.
It's not the center of the cone.
Okay.
It's a meridional.
Periphery. Yes.
It's slightly in the periphery. I don't go beyond 6 millimeter because of the unpredictability, and the closer to the center, I don't want to go. So this is the limited case series that we have.
Okay.
And so far, nobody has lost in spite of. So case selection is very.
Yeah. Thank you. Thank you so much.
Yeah. Okay.
Yeah. So should we switch to another speaker? Switch over to another speaker. The another speaker is Dr. Soumya Basant. She is going to talk on preferred practice pattern in dry eye. Dr. Soumya Basant?
Yes, am I audible, ma'am?
Yes. In a very short notice, all the national standards they have come, and I'm really, really thankful.
Thank you for having me here, ma'am. Really. Okay. Yeah, we'll start.
Yes.
Is my screen visible?
No.
No. Yeah.
Yes.
Visible? Yes.
Yes. And this is going to be helpful to PGs also.
Yeah.
This topic.
With advanced corneal procedures like CXL plus procedures plus CARES, back to a very basic thing, a structured approach to a dry eye clinic. Okay, what do you think is the prevalence of dry eye in this world? I compiled a few papers across the world, some few studies from US, Australia, and Asian studies. We had a large study done by Samar Basak et al. From Bengal. I mean, all the papers presented the prevalence of dry eye anywhere between 9% to almost 50%. This is the global magnitude or the burden of dry eye. So we really have to take a serious look at it. Why do you think there's an increase in the prevalence of dry eyes, change in our lifestyles, excessive use of air conditioners, computer usage, post-COVID era? I think even kids also started having online classes. All of them were using tabs or some kind of visual display units, increased awareness among the patients.
Sorry to interrupt, but I think your slides are not moving, and also your screen is not full screen. Yes.
Yeah, it's full screen for me. Now it is better.
I'm not sure. For me, it's not full screen, and your slides are not moving as well. I'm not sure of the others.
Let me go back. Let me redo it.
Ma'am, it's not full screen.
It's not full screen? For me, it is full screen.
Yeah. No, ma'am, it's still not visible. And it's not moving also.
Yeah, let me redo it. Is it visible?
Yes.
Yes,
Right
now it is.
Okay. Yeah. And increased refractive surgeries that patients are undergoing, use of preservatives, in the sense use of a lot of drops, over-the-counter drops. A lot of patients use, especially lubricants which have preservatives. Okay, all these preservatives can cause dry eyes, increase life expectancy, and change in the definition. We came across TOFS JHOS 2 and even JHOS 3, which was recently published, has retained the same definition. I will quote it verbatim because each word has a lot of bearing and a meaning. A multifactorial disease. Dry eye is termed as a dry eye disease, or shortly termed as DED. It's a multifactorial disease of the ocular surface characterized by a loss of homeostasis of the tear film and accompanied by ocular symptoms in which there is tear film instability and hyperosmolarity, ocular surface inflammation and damage, and neurosensory abnormalities play an etiological role. The last thing, which was an addition from the JHOS 1, was there's something called as a neuropathic pain, where this slide shows will come to the extreme right of the classification. All these are, will not, go into the details of this. This was the latest addition in JHOS 2, where there was, they're not fitting into any category, was termed as neuropathic pain, and they were referred to a pain clinic. And coming to the bottommost part, why this classification is important is the whole difference between JHOS 1 and 2 was they categorized it as aqueous deficient and evaporative. There's nothing like, classic, segregation. If you come across a lot of mixed variety, which is what we all come across, and very few cases of aqueous deficient and pure evaporative dry eye, the whole admixture is where you actually treat them. And they can present to your clinic with varied symptoms like irritation, tearing, burning, stinging, dry eye, foreign body sensation. They commonly come and complain as sand or gravel feeling in the eye. Something bothering them. They never really can pinpoint and say what it is. Photophobia, blurred vision, when they commonly say, especially these computer users, when after blinking, it clears up. This is a classic symptom they come up with. And mucoid discharge, a thready, stringy discharge, eye fatigue, especially computer users after prolonged usage of computers. And usually, how do we go about, assessing these patients? Whenever such patients come with these presenting symptoms, there are a lot of patients who come to your OPD. Not everybody, is categorized or treated. Whenever they come with these kind of things, they are handed out with dry eye questionnaires. There are plenty you'll come across. Some of them I've listed, but what I commonly use is the OSDI, and it is also widely used. It's called the Ocular Surface Disease Index. It's a screening tool. You can, download it from the net and give it out to your patients. It's a set of 12 questions based on the symptomatology, what the patient feels, and a scoring system is given. And you turn it at the back, you submit, and towards your right, it is shown you how to evaluate the score. A score of 0 to 100 is calculated. Anywhere between 0 to 12 is termed as normal. 12 and above is called abnormal, mild, moderate, and severe. Anywhere a score of more than 33 is termed as severe. So this is a basic screening tool, a very simple, efficient, effective screening tool that you can hand out to your patients in your OPD. Please keep it handy, and you can usually, it gives a lot of information. And who are the other OSDR questionnaire recipients? It could be your diabetics, peri and postmenopausal women who are on HRT therapy, computer users, all these allergic eye disorders like VKC and AKCs, contact lens users who have worn contact lens for a long duration, secondary to ocular chemical burns, and post-refractive surgery patients post 6 months, even they're still experiencing these symptoms of dry eye. Please take a look at it. Patients on a lot of systemic and topical medications. I have enumerated a lot of systemic medications, lot of anti-hypertensive medications, and topical. All the glaucoma medications do cause some kind of dry eye. Most of them I've enumerated. It's your prostaglandin inhibitors, your cholinergic agents, carbonic anhydrase inhibitors, adrenergic agonists, and even your allergic, to treat allergies, what we use olopatadine, amastadine, alcaftadine, all these also can cause dry eye symptoms. Antivirals, mydriatics, and most of the drops which have BKC as the preservative are notorious to cause dry eyes. Coming after you've evaluated, screened them, then comes the examination part. One is the external examination and the slit lamp examination. External examination, we carefully look at the eyelids. See, the ocular surface comprises of your cornea, conjunctiva, your lids, and their glands associated. So we take a careful look at all these structures. Eyelids, look at the any malpositioning in cases of ectropions, entropions, lag of thalamus, seven nerve palsies. Look at the blink rate of the patient. Especially in Parkinsonisms and all, the blink rate is drastically reduced. The normal blink rate in an adult is about 10 to 16 times per minute. It's an involuntary reflex. Look at the blink rate, whether it's complete or incomplete, and how it is. Then look at the skin features, scleroderma, any facial changes in rhinophyma in cases of acne, rosacea, any kind of seborrheic dermatitis, any trauma. It could be mechanical, chemical burns or thermal burns, which could have caused any cicatricial damage to the lids, causing secondary ectropions or entropions. Any joint deformities which give a lot of insight whether they have rheumatoid arthritis. All these autoimmune disorders have an association with dry eye. Any splinter, Raynaud's phenomenon, splinter hemorrhages underneath the skin. All this external examination carries a lot of importance. Next, coming to the slit lamp examination, go carefully and methodically from anterior to posterior. Look at the tear film, look for any debris, any filaments, any mucus strands in the tear film. Eyelashes, look for the position of the lashes. If there's any trichiasis deposits in the sense, look for any scruff or collarettes at the base of the lashes, suggesting of squamous blepharitis. Sometimes you can have greasy collarettes, that has to be treated. Any distichiasis, then anterior, carefully look at the anterior and the posterior lid margins. Look for any abnormality of the meibomian glands. Look for orifices metaplasia, atrophy, or it could be capped, or if you compress on it, you could have a toothpaste-like excretion from the meibomian glands. Look at the secretions, whether they're turbid, foamy, or there's any frothing at the edges of the lids. Careful attention has to be paid to all of these things. Look for any telangiectatic lid margins or keratinization of the lid, and document all these things. And there are few in-house objective tests that all of us can do at your clinics. Wherever you are in a medical college, a single practitioner, group practice, wherever it is, definitely anybody can do it. Carefully document the tear meniscus height. I'll go through one by one how it is done. And TBUT or TFBUT, it's called the tear film breakup time. Schirmer's 1 and 2. Ocular surface evaluation with vital stains like fluorescein, rose bengal, and lismine green. FCT, which is not commonly done, it's called the fluorescein clearance test. How do we look at the tear meniscus height? sorry, the distance between the upper edge of the lower lid and the visible junction between the cornea and the lower layer of the tear film. Usually better seen under cobalt blue film. The normal tear meniscus height is 0.2 to 0.3 to 0.7. Less than 0.2 is termed as decreased tear meniscus height. Commonly seen when you see a case of rheumatoid arthritis and all, your tear meniscus height is, it's invisible literally. Then coming, how do we assess the tear film breakup time? Again, this is recorded as a number of seconds that elapses between the last complete blink. You have to ask the patient to blink completely, not incompletely. And appearance of the first random dry spot in the tear film. It is viewed under the cobalt blue filter after staining it with lissamine green. After staining it with fluorescein. The normal is anywhere between 10 seconds and above. Mild to moderate is turned as 15 to 10 seconds. Less than 5 is termed as severe instability of the tear film. What we look at by looking at the TBOT is the stability of the tear film. Next, coming to the ocular surface staining, we use two vital stains. It's called dual staining. I use lissamine plus fluorescein. I don't use rose bengal. It causes a lot of stinging in patients with severe dry eye. So I refrain from using it. Yeah, but either ways, lissamine and fluorescein does the same thing. Most of them stain dead and devitalized tissues. Fluorescein dye stains the areas of cornea, conjunctival epithelium, any disruption of the junctions that are stained better with lissamine green. And if your lid viper epitheliopathy can also be seen better with lissamine green. Carefully document all this, because this is what I do in my dry eye clinic, document everything and then write the diagnosis, final diagnosis. Look for the staining pattern of the fluorescein on the cobalt blue filter, whether it's, there's a pattern. Sometimes you'll have like a, C wave pattern or any focal stains, whether they're coarse SPKs, fine scattered ones, and document in which quadrant they are. This is a scoring pattern which I follow from National Eye Institute. There are various grading systems. You have Oxford grading systems and there are plenty other. Whatever you stick to when the patient comes for follow-up, please follow the same system and document it. I take a color pencil and document the same things. The cornea is divided into 5 quadrants: central, superior, inferior, nasal, and temporal. And the sorry, I have a bad cough. The conjunctiva is also similarly graded both on the nasal and the temporal side. And it's very simple to follow. The number of SPKs that you have noted can be graded based on the severity as 0, 1, and 2, and 3, and summate all of them. Keep a copy with the patient in the file. It gives a lot of importance. After you've treated, you can see how much they're fared on consecutive follow-ups. Rose Bengal, same thing, does the same thing as lissamine green, but stings a lot, so I refrain from using it. It's better observed under red-free filter. It imparts a pinkish hue to the conjunctiva. Even the mucus strands are well, demarcated by Rose Bengal stain. Vance Jovel scoring is given for Rose Bengal. It's available everywhere for people to follow it. A simple scoring pattern where they've considered the cornea and the conjunctiva as a whole thing. This is how staining, especially the conjunctival stains, stand up with lissamine green. Coming to Schirmer's 1 and 2, Schirmer's 1, all of us know, evaluates a basal and reflex. 2, it is with anesthesia, so it's only basal secretion. We use a number 41 Fortman's filter paper, which is 5 millimeters wide and 35 millimeters long. How it is placed is, never place it touching the cornea. It is always between the medial 2/3 and the lateral 1/3. So it should not touch or irritate the cornea. And there are a lot of textbooks or papers which say whether to keep the eyes open or eyes closed. What I do is I keep the eyes closed because even the irritation from the sunlight, and no fans or air conditioner should be there. They should all be switched off. To avoid, any irritation even from the sunlight, I ask them to close the eye. Some people do it even with the eyes open.
Dr. Soumya?
Yeah.
Sorry to intervene.
Yeah.
Actually, we have kept 10 minutes for each speaker.
Yeah.
So please stick to
I'll wrap it up. I'll wrap it up, ma'am.
Yeah.
Yeah. And fluorescein clearance is not usually done because it's a lengthy procedure. And this is how we, after carefully evaluating, we come to a conclusion what we are dealing with. And the treatment is always, it has to be tailor-made based on it. Stage management, we go stepwise, always educate the patient, modification of the local environment, identification and potential modification, elimination of any offending systemic or topical medications, change them to preservative-free ones. Even some glaucoma medications are preservative-free, lid hygiene, and then we have other lubricants, and all of us, it's a different topic. I'm not dwelling upon it. And we have a lot of immunomodulatory drugs, basically corticosteroids, secretagogues, and LFA. It's available in the market since last year. It's Liftigrast, which is a lymphocyte antagonist. Then oral secretagogues and therapeutic contact lenses also can be used, especially large diameter scleral contact lenses can be used. They provide a lot of relief. I've used them in few patients with Sjogren's, primary Sjogren's. Then even surgical punctal plugs also I have tried in severe dry eye cases. Conclusion is a comprehensive approach reviewing symptoms, tear film quality, quantity, ancillary testing helps you in crafting a logical, evidence-based treatment plan. Thank you.
Thank you so much.
Thank you, ma'am.
And our next speaker is Dr. Divya. And her topic is infection post-therapeutic keratoplasty.
Yeah.
Please stick to the time, Dr. Divya.
Sure, ma'am. Is my screen visible?
Yes, it is visible.
It is? Okay. Yeah. Okay. So my topic for today, is it visible, madam? Yes. So I'm just
yes, very much visible, very clear.
Yes. So as we all know, TPK is a vision and a globe saving surgery. And despite all the efforts, reinfection again remains a significant challenge. While keratoplasty can actually address the primary issue, patients still feel, we may feel that they may be at a risk of reinfections. And reinfections following therapeutic keratoplasty are of a major concern. So basically, TPK is done as a primary procedure. I'm sorry, 1 minute. Is my screen visible? Yeah, okay. So yeah.
It is very much visible.
As a therapeutic to eradicate infection, and again secondary to maintain anatomical globe integrity, and again as form of visual rehabilitation. So this is basically the cure rate of TPK that that is present in the literature. We see that it can be very different. The cure rates can vary depending on the etiology. Bacterial ulcers generally do better than the fungal ulcers and acanthamoeba. So fungal ulcers account for almost the highest recurrence, as you can see here. In bacterial, about 3 to 6% of the ulcers go for TPK, and about 90 to 100% are successful. Whereas in case of fungal ulcers, 18 to 20% of the ulcers that are treated go for TPK, and out of which 69 to 90% again have reinfections. So this is the literature review. As you can see, a lot of studies done, many from India as well, and you can see that the recurrence of fungal is quite varied. Again, from 10% to about 32%, there is a chance of fungal recurrence. Whereas in bacterial, it is definitely less. So maybe the area where the fungus grows, the type of fungus, all these also can play a crucial role in deciding if a resurgery is needed. So why is recurrence more common in fungal ulcers? So actually most of the fungal ulcers, as we know, are usually done TPK is done in the very late stage. and a delay in the early diagnosis or inappropriate initial therapy are quite common. Apart from that, all the drugs that are available, the fungal drugs are all, unfortunately, they are fungistatic and not fungicidal. And the other thing with the fungi are they actually penetrate downwards into the cornea, deep into the cornea, reach the anterior chamber. They go to the anterior chamber angle. From there, they also go behind to the retroiris space and spread all around the lens. And finally, they can also invade the vitreous cavity. So they can be quite virulent, in terms of how they can infect your eyes. And in addition, they can also, go towards the periphery and infect the sclera. So all these are causes why fungal ulcers are more common with recurrence. So it is very crucial that you go ahead and, really do a good thorough anterior chamber wash when you're doing the primary TPK. So this is again a slide that actually shows, there is the risk factors, which is the fungal etiology, which is the retroiris exudates, hypopyon, infiltrates. All these can give you, the fungal etiology during your surgery itself. And it is also associated with pre-treatments with steroids, which is a very common practice where they just go and buy medicines over the counter. That is also, something that we have to primarily educate our patients and the community. Again, uncontrolled diabetes mellitus and lapse in the treatment. And surgical, when you go in for larger grafts, which means that your disease is already progressed and quite severe. And again, intra-op lens removal. So having the lens and, the lens diaphragm and the capsule intact actually acts as a barrier. It doesn't let the infection go in that easily. So again, timing of recurrence. So this is one of the papers published from India in the Cornea Journal, which actually tells us that the fungal ulcer kind of, starts coming back in the first week itself. Out of the 229 eyes that they studied retrospectively, about 8 had bacterial and 55 of them came back with a fungal ulcer. So as you see here, from the first week, you start seeing that the fungal ulcers kind of increase. So first, second, third, fourth, they kind of progress, but more so in the first 2 weeks, you see a lot of patients coming back. So this can again be the site of recurrence of an ulcer. Most recurrences start at the host bed. So this indicates that incomplete clearance of infection during surgery. And again, it reinforces the importance of adequate graft size and margins when you plan for your TPK surgery. So this is again, in site of recurrence in the anterior chamber. Again, AC exudates, which also suggests that there is deeper fungal persistence. So it is good to do a good thorough wash during your surgery. And again, retroiris and intracameral involvement can actually worsen your prognosis. And all these patients usually progress quite fast. So again, progression of recurrence, again, infection progresses from the graft host junction inward, as you see here. And this can again lead to, graft melts and, scleral melts. So once you have this, then your chances of restoring your anatomy or giving good vision to the patient becomes a little doubtful. So I know your salvage options become quite limited. So it is good to go ahead and do an early graft and make sure that your sizing of your graft is quite adequate. So this is also another thing. You see the graft here, the infection is still persisting and the graft size is a little less. So this is something you always have, a 1 millimeter clearance when you do these TPK surgeries. Again, multi-drug resistance, such as in Pseudomonas, Pseudomonas can be quite virulent. So today you would see a very small ulcer, but tomorrow, they would progress very fast. So all these patients have to be treated vigorously with medications and with surgery as well. So the treatment of recurrent infection, again, you again re-scrape and, culture them. You do a assessment of the button of both the door and the donor rim. You study that to see if there's any organism. Confocal microscopy is kind of become obsolete now. You don't have any more new machines, but if you have it, it's a great option. Again, you can either plan for medical or surgical options when you're treating recurrent infections. Avali, natamycin, and voriconazole. Again, tablet ketoconazole or fluconazole when your infection is quite deep. And surgical, again, AC wash with intracameral voriconazole and a repeat TPK. So how to prevent these recurrence? We have certain decision-making guidelines. So one is, ask for history of native medications, any onset of symptoms, what was the onset of symptoms to presentation, how long did it take, clear documentation of follow-ups, misplaced optimism, and again, donor culture. So it is good to, this is the TST protocol from the AIMS group, which tells us that topical natamycin 5% is first given 7 to 10 days. And if the ulcer is more than 5 millimeters or a depth of more than 50%, then you start them on systemic antifungals as well. If this patient responds well, then continue natamycin. If there is poor response, then, or if there is severe corneal thinning, or if there's any impending perforation, then you add topical voriconazole along with natamycin. And again, if you see a poor response there, then you go ahead with intrastromal or intracameral antifungal injections, or you go ahead with therapeutic keratoplasty. Again, if you see a good response in it, you continue with natamycin and voriconazole. But if there's a bad response, poor response, you repeat these injections at an interval of 72 hours. So, I'm sorry why my slide isn't moving. Yeah. So intraoperative considerations, again, as I said, 1 millimeter of healthy margin should be looked at, and all the you have to irrigate well and make sure that all the material, the fibrinous and purulent material is removed. Preserve the lens as much as possible, and wound closure has to be done well, either using 16 or 24 sutures, and intracameral antibiotics and antifungals at the end of surgery. So this is the post-operative considerations. This is more of a theoretical thing. I mean, you can take screenshots of it if you wish to know what it is. And due to want of time, I'm just skipping this. Again, pythium keratitis is something that could be quite, a nightmare for the treating surgeon, and also can be difficult for the patient as well, because, there's a high chance of losing their sight, and it mimics so much like fungal ulcer. So you have to look at a lot of clues like, guttering and, very fast progress of the disease to give you a clue that this is pythium keratitis. So this was actually they had done the use of cryotherapy and absolute alcohol, and they did find that the ulcer responds well. So what they did was a single freeze thaw method using a retinal probe, cryoprobe, which is 2 millimeters. They used the cryoprobe for about 7 to 8 seconds at the graft host margin or the limbus area. And in case of scleral extension, then they use 99.9% alcohol for about 20 seconds. And what they found, it's a very small number, but you can see that cryo used in 6 eyes, TPK recurrence was 15%, and cryo not used in 2 eyes showed a recurrence of 50%. But there seems to be, some improvement with using the cryo. The recurrence rate is a little less. Pythium can be quite difficult to treat. So in summary, as we all know, fungal etiology definitely carries the highest risk of recurrence. Retro-iris exudates and endophthalmitis worsen prognosis, and larger grafts also increase the risk of recurrence. So the take-home points from this is that most recurrences happen within 4 weeks, especially while under topical steroids. Fungal extension to the angles might not be, appreciated in the initial post-op period, but you will have to look for it. And then again, start steroids after 3 weeks under antifungal cover, if at all you wish to do it. Best thing would be to avoid it, but if at all you wish to do it, only after 3 weeks. And again, topical cyclosporin also seems to be a good alternative, and a lot of people do give that, and they do have good results as well. Thank you, Bharti ma'am, for the opportunity, and thank you, Jharkhand Ophthalmic Society, for having me here today. Thank you very much.
Thank you, Dr. Divya.
Thank
Your
you,
presentation is as crisp and beautiful as you. Very nice and very nice, very informative. And I think this is going to be very helpful for the postgraduate students. Very nice. And at such a short notice, you came. So, and proved so immensely helpful. So we are really thankful
Thank
to
you.
you.
Thank you for the opportunity, ma'am. Anytime. Thank you.
We will invite you in future also.
Thank you. Thank you.
So now over to Dr. Prafulla for his talk, preferred practice pattern in fungal keratitis. First, we will do an introduction. Dr. Bharti Sharma, madam, are you here? We are, Dr. Sunil
Yes,
is here.
ma'am.
Dr. Sunil is here. He will introduce Dr. Prafulla Marana.
Dr. Prafulla
Yes,
Marana
ma'am.
does not need
Yes.
any introduction, madam. He's
Yeah.
well
Please
known.
mute yourself. Yes. राशि तुमसे बात करना है.
So, good evening, everyone. So, I welcome Dr. Prafulla Maharana. He actually needs no introduction, but he is the additional professor at the RP Center, AIIMS, New Delhi, and he is the secretary, Delhi Ophthalmological Society. He is doing great work as a secretary JHOS. He has published 395 Google Scholar article, 163 PubMed index papers with H index of more than 30. That's a great number. 50 chapters in national and international books. The Best Surgical Technique Awards from Branchco, Australia, Young Achievers Award, Skars, Ajit Babu Manji Award, and awards for best papers in various conferences. He is the principal investigator in 2 ICMR trials, co-PI in 18 trials, including 2 multicentric international. He is the mentor of the Women Scientist for DBT project and editor of the 3 Amazon best seller in ophthalmology book. I think this is very useful books for the postgraduates. He is the editor Dose Times and 40, and he is among top 0.08% for the cornea and 0.196% for the keratoconus scientist in the world. So welcome, Dr. Maharana, for
Thank
your
you so
talk on the
much.
cornea. Yeah, welcome,
Thank you
sir.
so much.
Yeah, you can share your slides, sir.
Yes. Is it visible?
Yeah, visible, sir. Yes, perfect.
Okay, so thank you, Bharti ma'am, for inviting me for this talk. And whatever I could do, I have done this in PPT. I hope it will help the students and the delegates here. So myself, Dr. Prafulla Maharana, I'm currently at RP Center, AIIMS, New Delhi. Now, why do we need a preferred practice pattern in fungal keratitis? Because RP Center with Ministry of Health, we did a survey, and what we found in below 50-year patient in India, cornea opacity is the leading cause of blindness, preventable blindness. And one of the most common cause for corneal opacity is your healed keratitis. And remember, India is a tropical country, and our 50% of cases of corneal ulcers primarily belongs to fungal etiology. So that's why all the students as well as delegates here, we must know how to manage such cases. Now, PPP is preferred practice pattern that include details about diagnosis, etiology, everything. I'll just stick to the management part because as Bharti ma'am reminded us, we have just 10 minutes to complete our talk. So what is the challenges that are there in management of fungal keratitis? The biggest challenge, what I feel is, the penetration of antifungal drugs. And second is microbiology, because fungal diagnosis is not possible without microbiology. And in India, it's impractical to expect that all the practitioners, they have a microbiological setup with them. So that is a major problem. And this is my article, as corresponding author, we have published this major review and survey of ophthalmology. So if you want to know the details about pharmacological therapy in mycotic keratitis, we can go to that. This is the second paper that we have published, again, a review article on IGO. And this is the targeted therapy TST protocol that we have published from RP Center. So my PPT is based on these 3 papers. You can refer to those papers for further details. Now, causative organisms, although any fungus can cause keratitis, but remember in India, it's the Aspergillus, Fusarium, and Candida, and rarely Demoticus fungi. These are the main culprits. You should know this in your clinical practice. Now, when to suspect? This is a very important cause. How to know? Because you may not have a microbiology. The moment you suspect a fungal keratitis, there is a tendency to refer. But when to suspect? Any patient presenting with trauma, if there is, you have started broad spectrum antibiotic and there is no response, or the course is very prolonged, or the patient has history of previous use of antibiotics or steroids, then in those cases you must suspect. Now these are the few clinical features. As PG students are here, so I thought let them show some clinical signs. You can see here there is a hypopion, and then here there are multiple pithary margins with satellite lesions. Here you can see it's a post-classic keratoid. Here you can see there are hypate margin, and also few satellite lesions are there. Here you can see there is an endothelial plaque. Again, the hypate margin is clearly visible, and there is a fixed hypopion. And you can see here multiple satellite lesions are there. Here you can see a plaque. If you continue for antifungal therapy for a long period of time, you can land up in a plaque. And this is the same patient after debridement of the plaque. So these are few classical signs. And yes, whenever you see pigment, always think about dementitious fungi. So wherever these signs are there, you should think about fungal keratitis. And it's always go for a weight mount by 10% QH and culture with several dextrose media. Now, there are few adjunct investigative tools like ASOC and confocal microscopy. Confoscan is a good sensitivity test. It can give you an idea about filamentous fungi, septate, aseptate. ASOCT is useful only in few things like I'll just show you to know whether it's an infiltrate or a scar. See, this is the infiltrate. This is a paper that we have published from RP Center. In infiltrate, there is shadowing, but in scar, there is no shadowing. Also, it can show you endothelial plaque, the margin, the type of margin that you see. So these are all suggestive of fungal keratitis. But to confirm the diagnosis, you need a culture and smear confirmation of the fungal organism. Now, principle of management, that is the main part I'll be discussing today. And why this is important, it has been proven studies after studies that if you start the antifungal therapy early, the prognosis improves significantly. And second, if you avoid steroid in suspected cases of fungal keratitis, the complications like perforation and need for therapeutic graft consequently decreases. So these are the two important points that makes the diagnosis of early fungal keratitis essential. Now, for all practical purposes, natamycin is definitely the treatment of choice. I'll quickly move to this protocol that we have described. That will help you to know how to approach a case of fungal keratitis. So, in this study, what we did is we collected the data of last 5 years of fungal keratitis, smear or culture proven, and then we saw what intervention are there and what was the outcome. So, this is TST protocol for any general ophthalmologist. It's a very important chart. You should always remember this in your practice. So whenever you have a case of fungal keratitis, start with natamycin 5%, 1 hourly. That is the loading dose. And for all practical purpose, advise the patient for initial 48 to 72 hours, they have to put it round the clock. Round the clock means not only during the waking hours, also during sleep, as and when the attendant wakes up or the patient wakes up. Then after 48 to 72 hours, you can reduce the frequency to maybe 2 hourly or 1 hourly during the waking hours, nighttime no drugs, then 2 hourly, and then check for the response. There is a big difference in bacterial and fungal keratitis. Remember, bacteria responds within 48 hours, but fungal keratitis response takes at least 7 days or maybe 2 weeks also. So don't jump the medication or change the medication without waiting for a period of at least 7 to 10 days. If the good response is there, then continue natamycin. This is quite good enough to take care of the fungal keratitis. Now, whether we need systemic drugs, yes, there are trials like MUD trial which discourages use of systemic antifungal, but at RP Center we found all our studies suggest that yes, they definitely add some advantage. The indication I'll subsequently cover. Now, if there is a poor response, natamycin is not working, you have waited for 7 days, then what next? Then you have to add either voriconazole or amphotericin B. If you are suspecting candida, go for amphotericin B. If you are suspecting filamentous or fungal organisms, then you go for voriconazole. So we add voriconazole to natamycin, then we continue for another 7 to 10 days. Now, by the time 2 weeks, you will be sure that whether this organism is responding or not. If it is responding, continue it. If it is not responding, you have two choices. Either go for a therapeutic penetrating graft, which maximum corneal surgeon prefers, or if the patient is not suitable for a graft or you have hesitation, you don't want to do a therapeutic graft, you can use intrastomal intracameral injection of antifungal agents. In between, there are some methods like you can go for CXL. Few people have shown good result, but our experience suggests CXL is not that useful. But targeted drug therapy like intrastomal intracameral definitely useful in such cases. Now, there is a very common question, how much frequency you have to inject. So normally what we do, we repeat 3 or 4 injection at a gap of 48 to 72 hours. If there is good response, then we set back the patient to topical natamycin and voriconazole combination. But if that doesn't work, again go for a therapeutic graft. This is the overview of how you should approach a case of fungal keratitis. With our TST protocol, the success rate is almost 80%, which is as good as intrastromal or medical management group. Now, I said I'll enumerate the indication. At RP Center, AIMS New Delhi, we include systemic antifungals, especially for student. You can remember this mnemonic DACK, deep stromal involvement, scleral extension, or there is extensive ulcer, large ulcer, or when there is you have done a keratoplasty for fungal keratitis. Preferred drug is voriconazole, but nowadays a lot of authors are proposing itraconazole to have a better sensitivity. So voriconazole you can use 200 milligram BD, itraconazole 100 milligram BD for systemic use. What to avoid if you are managing patient? Always avoid topical steroids if it's a fungal. And one important thing, people, they usually taper the drug quite early. For fungal keratitis, remember, even if you feel clinically the ulcer has healed, at least continue natamycin QID dose for at least 4 weeks. Intrastromal, intracameral, these are the commonly used drugs. And I'll just show you a video how to do that. So this was a patient. You can see there was a deep endothelial plaque with AC exudate. So what we did was we made the entry and we did the intracameral wash with voriconazole as well as with intrastromal voriconazole. So all these plaques are removed. I'll skip to the technique of intrastromal. Yes. So this is how you give intrastromal voriconazole. Start from a normal looking cornea, go near the edge of the ulcer, then inject there. The aim is to achieve visible corneal edema, as you can see. So the target is to use 5 or 6 injections so that you can surround the entire infiltrated area by multiple barrage of your intrastromal injection. Ideally, you should use fresh needle for each of such attempt. Or if you feel that you have touched the infiltrate margin, they should always use a fresh needle. Don't use the same needle or there is a risk of needle tract infection. So this is how you achieve. And at the end of the procedure, you can see the entire area is surrounded by 360 degrees surrounded by intrastromal voriconazole. So this is how normally you do intrastromal voriconazole injection. Surgical management, yes, if it is an impending perforation or there is perforation or there is severe thinning or the ulcer is non-healing, then you should straight away go for therapeutic penetrating keratoplasty. In fungal keratitis, if your therapeutic PK you are planning, do it early. Don't wait very long till the ulcer reaches your sclera. So then that significantly reduces the prognosis of your graft. Post-therapeutic PK, Dr. Divya, she covered it quite nicely. What should be the protocol? Remember, if it is a fungal keratitis TPK, don't give steroid immediately. Wait for your culture report or at least keep a gap of 2 to 4 weeks before starting steroid for a graft. In India, the patient's main problem that we encountered is late referrals because by the time the patient reaches you, the ulcer has already reached the limbus. Even if you do surgical therapy, then the advantage is not there because scleral involvement, long antibiotic, and glaucoma, NVG, all these complications already has started. Limited microbiology, we have seen a lot of patients referred to us with a cocktail of therapy, suspected fungal, suspected viral, and all the drugs have been started that one should avoid and one should avoid. The key take-home messages: whenever you see a case of vegetative trauma and then keratitis, then always suspect of fungal. Natamycin is the drug of choice. Remember that. Avoid steroids if you are suspecting fungal, and timely surgery. Don't delay TPK too long. And I'll conclude with this article just we published in RP Center, just published in IGO this year only. So this is an important study that we did. What we did was for the first time we measured the intracorneal concentration of drugs. It was a thesis done by my thesis candidate Vinay Patil. I was the chief guide for him. So what we analyzed, we compared the intracorneal concentration and with MIC 90. What we found, even if the drugs are reaching beyond MIC 90, a lot of fungal keratitis cases, they were not showing a response to our medical therapy, which indirectly indicates it could be due to drug resistance. So this is probably the emerging trend in cases of fungal keratitis that we are not aware of. So these are the references that I have used for this presentation. And with this, I'm currently the secretary JHOS. Our annual program is 24 to 26 April. You all are invited. Thank you so much. And as sir was saying, these are my books for students. If you wish, if you want, you can read these books for your exam as well as theory knowledge. Thank you so much.
And he is standing for AIOS scientific committee membership also.
Thank you, ma'am.
We all will support him. क्यों
Thank you
डॉक्टर
so much, ma'am.
लोग सपोर्ट करेंगे ना इसको?
Yeah, sure, ma'am. Sure, बिल्कुल.
भारती हम लोग करेंगे डॉक्टर प्रफुल्ला को सपोर्ट.